Andrea has exhibited ongoing right-sided patellofemoral joint pain for the last 6 months. This type of knee pain is often caused by imbalances in the forces controlling patellar tracking during knee flexion and extension, particularly with overloading of the joint. This isn't surprising, with Andrea being a keen runner participating in both half and full marathons. According to Sayed Hoisen et al., the cause of this disorder can be divided into three different categories: local factors, which are factors that are related to the knee joint, patellofemoral joint, and nearby tissues; distal factors, which are related to foot and ankle joint mechanics; and proximal factors relating to pelvic and hip joint mechanics. These factors may include muscle weakness or soft tissue shortening, biomechanical changes in the lower limb structure, muscle imbalance, and quality of movement. It has been suggested by studies conducted by Nascimento et al. Weakness of hip adductors, lateral rotators, and extensors is thought to lead to excessive hip adduction and medial rotation, which contributes to altered patellofemoral joint kinematics and patellofemoral joint stress. It is important when interpreting the client's assessment results. Emphasis on analyzing the client's hip abduction and hip extension is of great importance. Andrea also has a history of bilateral Achilles tendinopathy. It is a common overuse injury relating to the loading that is placed upon the Achilles. The injury occurs because the tendon isn't able to adapt to the stress or sudden loading it is being put under. It is commonly aggravated by running or jumping when compressive forces are placed on the ankle, specifically in dorsiflexion. Broach et al. Determined that there are many different variables that can contribute to patellofemoral joint pain. Amongst the considerations are excessive Q angle, excessive foot pronation, weakness of the vastus medialis, misalignment of the patella, maltracking of the patella, joint laxity, and decreased mobility of the hamstrings and/or quadriceps. When interpreting Andrea's clinical assessment results, it is obvious that she inhibits most, if not all, of these variables. Results that were of most concern were relating to her hip range of motion as well as a positive Thomas test and signs of Trendelenburg. The noticeable Trendelenburg signs on the right side indicate weakness in the hip abductor muscles, specifically the gluteus medius and minimus. Weakness of these muscles cause internal rotation and increase the Q angle. This increased Q angle is linked with knee valgus, which was apparent during the single leg squat. Patients with a larger than normal Q angle may be more susceptible to patellofemoral pain because the patella has a tendency to track more laterally. Haim 2006 reported an abnormal Q angle of greater than 20 degrees was statistically associated with this pain. Testing Andrea's Q angle would be beneficial in understanding if this can be a credible link to her pain. Andrea has 0 degrees in hip extension. This limited range is from poor gluteus maximus strength, which is noted to be a significant factor in patellofemoral pain etiology. According to Roach et al., it has been observed that female subjects with patellofemoral joint pain have a significantly decreased hip extension and hip abductor torque production as compared to healthy counterparts. When assessing Andrea's knee-to-wall score and dorsiflexion range of motion, it can be noted that both are of high concern. During the knee-to-wall, it is apparent that her right side is a lot more affected. Poor ankle dorsiflexion is indicative of a low knee-to-wall score. Because of the notion of the kinetic chain and that joints and segments have an effect on one another during movement, it is not surprising that the small degree of ankle dorsiflexion that can be seen in Andrea has a repercussion and has subsequently had an association on greater knee valgus displacement. During the landing phase of running, if there is a limited amount of dorsiflexion, there is consequently decreased knee flexion, which results in greater ground reaction forces, and these greater ground reaction forces are associated with greater knee valgus displacement. All of Andrea's manual muscle testing results were either a 4 out of 5 or 5 out of 5. This score indicates that the client was able to complete a full range of motion while the practitioner was applying a moderate resistance. Herbertoloza et al. Concluded that the normative result for a single leg calf raise for women was 21. Andrea scored 12 on her left and only 10 on her right, as well as reporting a dull ache in both her left and right Achilles. Randomized controlled trials have shown the effectiveness of eccentric strengthening exercises in the management of Achilles tendinopathy. Not only will the eccentric strength exercises increase gastrocnemius and solar strength, it will subsequently help with the management of Achilles tendinopathy pain. Increasing hip extension range of motion has been recognized in the treatment of persons with patellofemoral pain. It has the potential to reduce pain and improve performance of activities of daily living. This is considered one of the goals for Andrea. She currently has 0 degrees. Improving range of motion will not only be beneficial in pain reduction, but studies have shown that hip extension is important in maximizing running efficiency and reducing running injury risks. Hip extension, coupled with knee and ankle extension, produces the power phase which drives running forward propulsion. A strong gluteus maximus is a must for hip extension in runners. The gluteus maximus is the primary hip extender while the hamstrings assist. This is why increasing gluteus maximus strength as well as medius and minimus is another goal we have created for Andrea. Increasing the glute max strength is relevant for hip extension, whilst increasing glute med and min strength will help with hip abduction and in turn reduce the Trendelenburg symptoms. The weakness of these muscles causes drooping of the pelvis to the contralateral side while walking and or performing a squat. Increasing ankle range of motion, particularly dorsiflexion, is extremely important. Right now, Andrea only has 5 degrees of dorsiflexion on both the left and right ankle. 17 degrees of dorsiflexion is needed for running, so if Andrea wants to continue running, particularly without pain, it is important that one of her main goals is to improve this range of motion, as well as increasing gastrocnemius strength. With the knee extended, Kaufman et al. Found that limited ankle dorsiflexion, lower than 11.5, was associated with Achilles tendinopathy compared with normal ankle dorsiflexion of between 11 and 15 degrees. The final goal for Andrea is increasing quadriceps strength. A study conducted by Peter and Tyson in 2013 determined that exercise therapy was consistently found to be effective in reducing pain in patients with patellofemoral joint pain. With programs traditionally focused on improving quadriceps strength and vastus medialis function. The use of open kinetic chain exercises were also seen to be more effective at reducing the pain. Improving Andrea's quadriceps strength will also link with her own goal of reducing pain to allow her to run in half marathons. Andrea's program will begin with 5 minutes on the bike. This will be used as a warm-up cardiovascular-based exercise. The bike will reduce the force impacts placed through the knee that can be seen in running. Other warm-up exercises include mobility activation. The sit-to-stand will be used to correct technique of the squat and focus on reducing the noticeable Trendelenburg sign, which is excessive pronation and hip and knee valgus. The open and close the gate exercise will be used as a functional dynamic warm-up to activate abductors and adductors. The final warm-up exercise, the resistance band dorsiflexion, is to activate the ankle dorsiflexor muscle group. A goal of the program is to improve dorsiflexion range. It is important to improve this range because according to Scatone Silva et al., lower ankle dorsiflexion was associated with worsened symptoms in Achilles tendinopathy patients, so increasing this range will hopefully decrease pain in the future for Andrea. In terms of the main program, the exercises chosen were relating to both practitioner and client goals. Increasing strength in the quads and glute muscles, as well as improving hip and ankle dorsiflexion range of motion, have all been shown to be helpful at reducing both knee pain and pain from Achilles tendinopathy. The Spanish squat is used to generate strength in the lower extremities without overloading the anterior knee structures. It allows for heavy loading of the quadriceps with decreased patellofemoral pain. Patellofemoral joint pain is also associated with decreased hip strength, specifically at the abductors and external rotators. The banded clam is an important exercise in Andrea's program as it strengthens these specific muscles. According to Rabic et al., heel raising and lowering exercises are typically suggested for Achilles tendinopathy rehabilitation. This is an important aspect for Andrea's program, specifically in increasing her knee-to-wall score and reducing pain. The donkey kick exercise correlates with the goal of increasing glute strength. Strengthening the glute, which is a primary hip extensor muscle, would subsequently increase the likelihood of Andrea gaining range of motion when in hip extension. Improving hip extension has been seen to be a protective factor in reducing pain caused from the patellofemoral joint pain. Some of the progressions for Andrea will include changing the warm up from the bike to the treadmill. Monitoring her pain through this small 2 kilometer warm up will be of great importance. Changing the sit to stand to a TRX held squat will add more weight to the squat while still being able to hold the correct technique with the use of the TRX. Open and close the gate will be changed to A skip. This is a more functional running mechanic that can be used for Andrea to slowly increase her weekly split. Increasing the time holding the Spanish squat, changing the banded clamps to the Copenhagen plank, introducing a single leg glute bridge with a ball squeeze instead of the wall slide with ball squeeze, adding weight and progression to a single leg heel raise, and adding a dynamic component to the slide lunges to skater lunge, and adding weight to the donkey kicks by using a Smith machine.